And welcome to the Dr. Bob Show. We'll be spending most of this show talking about your entire GI tract, starting with the swallowing, starting with your esophagus, going all the way down to your stomach, and then the duodenum, then ulcers, then cancer of the stomach, cancer of the esophagus, then the GI tract. We'll be talking about what causes diarrhea and constipation, and what's ulcerative colitis, and what's Crohn's. Whoa, those are a lot of medical names and problems. We're going to be covering those common symptoms that you and I both have, and what is the underlying cause, and do I need to see the doctor? My guest is Dr. John Haydek. Dr. Haydek is a board-certified stomach specialist, gastroenterologist, and he'll be answering our questions. And I am so looking forward to this show. Hello, I'm Dr. Robert Overholt. I'll be your guest for the next 30 minutes. We're going to try and see how exercise, proper sleep, proper eating, and being happy will also help control your GI tract. I'm going to see if Dr. Bob can integrate all those things so you'll have a happy belly. We're talking with Dr. John Haydek, board-certified gastroenterologist. That's a stomach specialist. And we're going to be walking down the GI tract. John, welcome to the Dr. Bob
Hi, Dr.
Show.
Bob. Thanks for inviting me again today.
It's a delight always to have you on the show. Tell me, what does a board-certified gastroenterologist mean? What kind of training did you have to have?
Well, to be a gastroenterologist, you need to be a good internist first. So you first spend your time with medical school and residency to be a good general doctor. And then you would go for extra training for 3 or 4 years to be a gastroenterologist.
3 or 4 years?
And then you could even go more if you wanted to be
Whoa.
liver or inflammatory bowel disease or specialized in scopes.
So it's getting to be more and more and more
Yes.
special. It's a long time. It takes a lot of medical training.
But the body's complicated, and there's so many different things that can happen. So I think the training just assures that you're well trained to be able to take care of people.
When you got out of all of this training and you were the smartest GI guy in the whole world, were you nervous about seeing the first patient?
You were, because you no longer had your mentors and your other people behind you. But you learn and you develop your own style. Medicine is an art. It is not a science per se. It's an art of how to take care of people.
And sometimes we're really good at telling you what you don't have, but sometimes if I've got a pain, we know how to work it up and rule out the bad stuff, but sometimes we end up not knowing exactly
That
what the
happens
patient
a
has.
lot, and maybe more than what we want, but the vast majority of pain people have, you never quite know what it's from, because the majority is gas or bloating or irritable bowel syndrome.
Yeah.
Then those can't be diagnosed easily.
And we're going to get down to that later on in
Okay,
this
I'm
show.
ready.
First of all, I want to start about hiatal hernia. What's a hiatal hernia?
A hiatal hernia is a little pocket that develops above your stomach. So your esophagus ends where your chest ends, and then where your belly starts, your abdomen, is where the stomach comes. A hiatal hernia is where the stomach herniates or pushes up into the chest. So you have part of your stomach in your chest.
Wow.
And that develops a little pocket.
Can you see that, John?
You can sometimes see it on an x-ray. You can sometimes see it with a scope, of course, or an upper GI study. You couldn't quite see it on physical exam, no.
But if that hiatal hernia comes up into the chest, does it hurt your heart or does it hurt your
Well,
lungs?
if it's really big, it'll push it from side to side, or it'll sometimes crowd things out. And some people with really large hiatal hernias are short of breath because their lungs just can't expand there.
So does that always lead into an ulcer, or what symptoms does a hiatal hernia cause?
Well, most of the time, hiatal hernias don't give any symptoms at all. Most people with bad reflux have a hiatal hernia, but people with a big hiatal hernia don't always have reflux, so it doesn't fit both ways.
So how is a hiatal hernia found? How does a patient suspect, I got a hiatal hernia? They got to have some kind of symptoms.
Usually it's food-induced fullness when they eat,
Burp a lot?
Well, no, burping is a common symptom that people get frustrated from. But burping, you know, Dr. Bob, is nothing more than your stomach getting rid of the gas you just swallowed. Our stomach doesn't make gas. Our intestines don't make gas. Our colon makes gas, but that's 17 feet down. So when you're burping, you're getting rid of swallowed air. Now, every time we swallow saliva, we swallow some gas. We're all different. Some people swallow more gas than others. So people who burp a lot may have like reflux disease because they salivate more. People who chew candy or suck on mints will swallow more, and they may burp some more.
So that they swallow the air and the air burps up. Let's talk about the swallowing tube, the esophagus. I had some food stuck one time in my esophagus. What does that feel like?
You get the pressure because your body knows there's something in there, and you'll get the squeezing pressure. Sometimes can hurt a lot, and you'll hypersalivate or make a lot of saliva because your body knows there's something wrong and they're trying to push it down. So that's a classic finding. You'll get squeezing chest pain, and you'll get lots of saliva, and you'll be irping up that stuff.
So if it's in the esophagus, what's the key symptom that the doctor knows? So when I had it, I knew I'd swallowed some chicken that was stuck. I talked with a gastroenterologist who then said, I know what it is. If it happens again, let me know. It happened a second time a month later, and he said, I'm forced, I know it's going to be normal, but we have to look for other things. What are they looking for?
Well, they were fearful because dysphagia or trouble swallowing can sometimes be related to cancer. So that's the big fear we have when somebody has a new onset trouble swallowing. Now, if someone said, I've had trouble swallowing solid foods like beef and chicken and cornbread for the past 5 years, that's probably not cancer. But if someone said, for the past 3 months, I have this new onset trouble swallowing, and first it was bread, and now it's liquids, and I've lost some weight, that's a warning sign that there's something wrong.
So can you look with a scope and see what
Absolutely.
it looks like?
Well, the first thing, Dr. Bob, don't forget, is you take a good history, because from the history you could tell. If someone says solid food causes me issues, but liquids are fine, it's a kink, a narrowing, or an allergy, eosinophilic esophagitis. If they say solids and liquids both cause me trouble, that sounds more like the muscles don't work. Food goes from here to here. It doesn't like fall, but our food tube in a nice coordinated way pushes it down. So if the muscles weren't working, liquids and solids both would give issues when they swallow.
What's a stricture? If you have a stricture, what's that going to be like?
That'll be scar tissue. That'll be solid food giving them issues. Liquids are usually fine. Strictures can be caused by acid reflux or allergy, or sometimes cancer.
How do you open it up if it's a non-cancerous stricture?
Well, we would stretch it. So you would take the scope, you'd sedate them so they're very comfortable, and you would go with the scope, and you'd actually put a wire with the scope into the stomach, and then you pull the scope out. So you now have a wire that comes up out their mouth. Remember, they're very comfortable sleeping. And then you take different sized tubes and you just stretch, and then you take a look and say, did I do something? Nah, I didn't do anything. Bigger size, stretch. Oh, I'm starting to rip open. That's how you open up scars. You gently rip it open.
So you've got ways that you can dilate up the stricture. So patient gets out of their scope and you've told them how you're fine, it's okay, I want you to stay away from acid, look for GERD. What is GERD? How is reflux different than hiatal hernia?
Hiatal hernia is something you see. GERD is really something you feel. GERD is where acid comes up into the esophagus and causes you to change things. Like it's a disease, it causes you to take medicine or avoid foods. Heartburn is just a symptom. It doesn't make us change or do anything different. So they're a little bit different.
Could that heartburn be an ulcer, or could it be a cancer in the stomach? Is there a reason you need to go down and look at that?
No, you're right.
And that's what we're going to
Dyspepsia.
be talking about when we come back. Dr. Haydek just said dyspepsia. What's dyspepsia, and does that mean you've got cancer, don't have cancer, have an ulcer? We're going to talk about that when we come back. We're talking with Dr. John Haydek, board-certified gastroenterologist, stomach specialist. We've been talking about swallowing and the esophagus and how problems can happen there. We've talked about a hiatal hernia. We've talked about burping. We've talked about how you need to dilate a stricture. We said when you look down, you've got to rule out cancer. So if you've got symptoms, be sure if they persist or get worse, you go to the doctor who takes a good history. When he takes that good history, he'll know what to do. Now we talked about dyspepsia. Let's talk about ulcers. What's the word dyspepsia mean, John?
So dyspepsia is this acid, full feeling, usually food related, right in the middle where they eat, they get a little bit of bloatedness, they may feel acid in there. And the problem with that symptom is that it's very non-specific. It could be related to acid reflux, it could be related to irritability in the stomach, functional dyspepsia, or it could be related to bad stuff. Even the gallbladder can sometimes hurt there.
Wow, so the word fullness and upset in the upper part of the stomach makes the doctor begin to think.
Absolutely.
And when the doctor thinks, what does he think of could be causing problems of fullness in the upper abdomen?
Well, you again take a good history, and in your mind you're saying, think of acid or ulcer, think of gallbladder, and think of irritable bowel syndrome. Those are the big three things that go through your mind. And then you play Clue. Do you know the game Clue, Dr. Bob?
Yeah.
So you play the game Clue and you start asking, does it seem like it's related to greasy foods or spicy foods? Nope. And then you'd say, okay, probably not related to this. Does it sometimes happen in spells like gallbladder with normal periods in between? Yep. That's what it sounds, and then you start saying, gosh, that must be gallbladder disease. So a history really helps you.
What are the symptoms of gallbladder disease?
Gallbladder is intermittent episodes of pain with pain-free intervals in between where they're perfectly normal. The pain episodes are about 30 minutes. The pain starts and slowly peaks, and then it's constant, full pain, sharp. It may go to your back, you may get nauseated, lasts minutes to hours, then it goes away. They feel great.
What brings that on?
Usually fatty foods can sometimes do that. Sometimes it just happens overnight and wakes you up.
So the gallbladder puts out enzymes that help digest food. So when we eat food, we can get gallbladder attacks.
Absolutely.
What if somebody's jaundiced?
Well, if you're jaundiced, then you're going to say, there's a blockage somewhere, or the liver's not working, one of the two.
So you need to look at how the gallbladder is squirting out the gallbladder.
Well, you'd probably
juice.
do an ultrasound or a CAT scan. If they get jaundice, we get nervous. And then there's painful jaundice or painless jaundice. Painless jaundice is a worrisome finding that there's a blockage somewhere, and cancer is the big thing you worry about.
So you've got to worry about something that's blocking, like cancer, the pancreas that blocks the duct, or the gallbladder itself. Can you get cancers?
Sure, the gallbladder can get cancers, or you can get stones in the gallbladder that trickle out into the little tubes called the bile ducts, and you can have trouble there. And there's a special procedure we do that you could open that up and remove the stone. It's pretty neat.
Yeah, that sounds fast. Okay, away from the gallbladder.
Yep.
Let's go back to the stomach. Reflux disease, heartburn, dyspepsia, the fullness that we've got there, and there's a difference between the two. Now, how do you diagnose reflux disease?
By a good history of food-induced issues, and then improvement when they take acid-reducing medication.
So there are medicines. Give me the name of a couple of medicines.
Oh, Tagamet, Pepsid, Zantac off the market, Prilosec, Nexium.
So there are a lot of good. Are they good? Do they work good?
Oh, they're excellent. They all work really well.
If patient doesn't get better on those good medicines, what do you think of?
You have to start wondering, this is probably not acid. this is something else, which could be irritability, bile reflux, infection. You always got to put cancer in there.
Okay.
Not the 19-year-old.
Sure. But that's for your history and your differential diagnosis. If you have to look down to make the diagnosis, tell me what that's like.
Well, back in the old days, endoscopy was a little difficult because we couldn't sedate our patients well enough, and we would have to use old-time medicine, and patients were awake or conscious, and it's not fun having a tube down. But with modern medicines nowadays, we're able to put people completely to sleep without a breathing tube or intubation, and they just lay there with their mouth open, comfortable, dreaming, and you can just take a tube and look down the food tube, stomach, and first portion of the intestine called the duodenum.
So when you're looking down and you're in the stomach, what does a stomach ulcer or what does stomach cancer, which is what we're trying to be making sure we rule out, what do they look like? What's an ulcer and cancer look like?
An ulcer looks like a scrape or a sore or a divot. You know, have you ever divoted on the golf course, Dr. Bob?
No, they won't let me play on a golf course.
See. But that's how an ulcer looks. It looks like a divot on a golf course. You'd have the nice green with this hole of a different color.
Is that treatable?
Obviously, it's white and pink in our stomachs, though.
So is that ulcer treatable too?
It's treatable by, well, most of the time we treat ulcers by taking away the offending agent. So by taking away acid, Nexium, Prilosec, Pepsid, you allow the body to fix it. The body fixes the ulcer. The pills don't. The body's, with good nutrition and good health, the body fixes it.
So if you listen to your body, you've got a good chance of knowing whether you need to see the doctor or not. What does the cancer look like?
Cancer's ugly. You don't need to be trained to look at most cancers and be able to say, oh, that doesn't look good. It looks red, inflamed, weeping. So most cancers are pretty obvious.
If it's down there and you look at it, can you take pictures?
Oh, sure. Frequently, that's a good way for patients to understand. Because if you could show them a picture of what's happening, they could really understand things.
Do you take a biopsy, and what does biopsy mean?
Biopsy means taking little bits of tissue that are then looked at underneath the microscope to give you a diagnosis. We take these little alligator clippers, and they're on a big long stem, and we push them down the scope, and they come out the end, and we say open, and they open like an alligator clipper, and we close, take a piece, and then we pull it out.
So the pathologist then looks at it and says it's cancer. Are cancers of the stomach bad news if they haven't spread, or can you surgically or medically correct that?
Most of the time, you're not finding stomach cancer early. You're finding it too late. So it's usually a bad diagnosis to have. But this is 2021. The amount of things that they can do now with the scopes or with surgery, with chemotherapy, checkpoint inhibitors. There's so many things that we never could do before.
Isn't it great to be able to see things in the past that were, I'm sorry to talk with you, but you've got cancer and the chances of living. Now we can say, bad news, you've got cancer. Good news, we do really good on the treatment.
That's exactly right.
On the treatment of that. After food goes through the stomach and the duodenum, what's next in line?
Next in line is this tube of about 17 feet long called the small bowel.
And after the small bowel is what?
The colon.
And does the colon have diseases?
Colon has lots of diseases.
And that's what we're going to be talking about when we come back. Dr. Haydek is just so full of information he wants to give. We're going to be talking, if we can, about ulcerative colitis, about Crohn's disease, about irritable bowel. What's the difference in irritable bowel and IBD, infectious bowel disease? A lot of different things that we've got to learn. Well, we're going to learn it when we come back. We're talking with Dr. John Haydek, board-certified stomach specialist, gastroenterologist. Remember, we've talked about the esophagus, strictures, possible cancer, scoping. Then we talked about a hiatal hernia and reflux disease. We've talked about the word dyspepsia, which is the fullness in the stomach. We've talked about gallbladder and gallbladder attacks. We've talked about ulcers. The treatment of those are great. If you've got symptoms that don't go away, be sure you get those looked at. The gastroenterologist can look down and you won't know anything bad that you're having a scope. Now we're going to drop down to the lower part of the belly. I've always worried about the words IBD, whether it's irritable bowel disease or it's infectious bowel disease. Let's go to what are the infections in the bowel disease?
Well, there's IBS, there's IBD, and then there's infections. Infections would be bacteria or viruses or fungus that affect the colon. It'll make the colon weep, get red, get inflamed.
What do you call that?
Infectious colitis. Could be C. difficile colitis, could be salmonella infection, could be Shigella. So there's lots of infections.
So they're a big time. What's ulcerative colitis?
Ulcerative colitis is an autoimmune thing where the body attacks the colon. We don't know what causes it. We know that there's a predisposition and something turns it on, and what that key is we don't know.
When you do a scope on that person, a colonoscopy on that person, where you look in the colon, what does it look like if they've got Crohn's disease?
Inflamed, red, mucousy, but it looks similar sometimes to an infectious colitis. So in the very beginning, it's sometimes unclear, is this an infection colitis or an autoimmune ulcerative colitis or Crohn's disease?
Are there new medicines for that?
There's so many more new ones now.
Are they called biologics?
They're called biologics. And
how does that work?
Biologics are sort of medicines that work in a specialized way to treat the immune system. They're not just generalized anti-inflammatories, but they actually work on specific pathways. They're usually injection, not all of them, and they're very effective, but they tend to be expensive. They tend to require a lot of monitoring there, but they give patients back their life. Back in the old days, we only had steroids to treat them, but we now have so many different things to make them feel normal.
So these biologics we see for ulcerative colitis and Crohn's disease, that we see those on television where people really look like they're really doing great. Do they do good?
Yes, they do. Now, not 100%. Nothing's 100%, but 40, 50% will do really well on them.
Okay. Now, when you're treating somebody with infectious bowel disease or you're treating somebody with inflammatory bowel disease, you've got good medicines. You do a good job. What's the irritable bowel?
Irritable bowel is it's confused with, but it's completely different. Irritable bowel is irritability in the nerves and muscles. The skin is normal. There's nothing wrong with IBS. The colon is perfectly normal to the eye. It just doesn't function the way it should. And that function changes. There are good days and bad days.
If I've got irritable bowel disease, and I've been to the doctor a million times and my belly still hurts and it's just not getting better. You do a scope and everything in the scope looks normal.
Right.
And you've gone back and say,
right.
I am sick. We treat with lifestyle changes. Do those help patients?
A ton. Lifestyle is the way to go when you have irritable bowel. Now, it's hard. Lifestyle is hard to try to avoid certain foods that make things worse, to try to exercise, to meditate or have a positive thinking.
Yeah.
It's really hard to do that in our busy lifestyle, but it's important.
So we've got to have lifestyle changes. We've got to exercise. When people exercise, it seems that that's part of the treatment for everything. Does it help an irritable bowel?
I think it calms the mind and it makes the body feel better in general, and when you do that, irritable bowel tends to get it doesn't go away, it doesn't cure it, but it tends to be less bothersome when you have a good, healthy lifestyle.
And we know that exercise does reduce anxiety.
Yep.
We know that it lowers the blood pressure. We know that it allows people to sleep better. that they get healthier in general, and the GI tract and irritable bowel will do that. Now, let's talk about eating the right foods.
Yes, very healthy. People with IBS should avoid gas-producing foods like beans, broccoli, cauliflower, cabbage. Very healthy, very bad though if you have IBS because of the gas production.
You have to watch what you eat, and you have to work out that with your doctor. How about proper sleep?
Sleep's always important. It'll help reflux disease, it'll help weight gain, and it'll help weight loss. So no, sleep's important.
You know, if you don't get enough sleep, nothing in the body works.
I agree with you.
How about laughter, socialization, and being happy in order to get a happy GI tract?
Symptoms of IBS when you're happy are less bothersome than symptoms of irritable bowel when you are unhappy. And therefore, happiness blunts the symptoms.
So exercise, eating right, sleeping right, and laughter. We know that laughter helps the immune system. And the immune system has got to work good in order to get the immune action of the treatment to get better. So like we say in the Dr. Bob Show, exercise, eating properly, sleeping properly, and having a lot of laughter.
I like it, Dr. Bob. I like that.
Yeah, a happy mind, a happy person, happy GI tract.
Yep.
John Haydek, you are a fabulous
it's nice
teacher.
to see you again.
Thank you for coming to the Dr. Bob Show. I've had so much fun asking Dr. Haydek questions. I hope you've enjoyed this show. Stay happy.